Rwandan National Neonatal Protocol, Neurology, with Dr. Febroni Mushimiyamana. Introduction.
Hello, I'm Febroni Mushimiyamana, a pediatrician from Rwanda Pediatric Association, and today we are going to talk about neurology.
Overview. By
the end of this chapter, participants will be able to identify appropriate temperature for newborns with hypoxic ischemic encephalopathy, HIE, explain the diagnosis and the management procedures for seizures, identify dangerous side effects of anticonvulsant medications, identify a treatment for pain associated with minor procedures, identify a treatment for pain associated with major procedures.
Considerations in neonatal neurology.
Asphyxia, defined as inadequate delivery of oxygen to meet metabolic needs, is the #1 cause of death in neonates in Rwanda. Risk factors for asphyxia are related to the fetus, mother, and the placenta. While prenatal asphyxia is very rare and not preventable, asphyxia during labor or immediately after labor is more common and a very preventable one. Prevention strategies include active management of labor, detection of fetal distress, prompt management, and immediate restitution with the goal of breathing within 1 minute. The goals of this module include harm reduction and how to optimize outcomes of babies who suffer from asphyxia to ensure happy, healthy childhoods. Hypoxic ischemia encephalopathy, or HIE, is caused by inadequate pre, intra, and/or postpartum oxygen delivery and blood flow. Signs and symptoms include delayed first breath, need for neonatal resuscitation, low APGAR scores, less than 5 at 5 minutes, absence of cry at 5 minutes of life, an abnormal neurologic exam, abnormal tone, and seizures. The severity of HIE should be assessed by SANAT stage. Stage 3 is the most severe with the worst prognosis, while stage 1 to 2 have minimal to moderately advanced long-term outcomes. There are 3 main principles for treatment of HIE. Avoid hyperthermia, provide supportive care, and monitor for and treat seizures. To avoid hyperthermia, avoid bundling and the warmer or incubator in order to keep the newborn's temperature under 37.5 degrees Celsius, which will help decrease ongoing brain damage after initial perinatal injury. Allowing newborns to get cool is only meant for babies with asphyxia and concern for HIE and should be avoided in all other cases. When providing supportive care, start experimental oxygen if the newborn is experiencing respiratory distress or has an oxygen saturation below 90%. NPO is if respiratory distress or seizures or SANAT stage 3. Give IV fluid with dextrose 10% at 60 ml per kg per day to avoid cerebral edema. Monitor and normalize the newborn's glucose and electrolytes. Neonatal seizures should be quickly diagnosed and aggressively managed. Clinicians should take frequent vital signs and monitor the newborn closely. Neonatal seizures can be subtle compared to those in older patients, so it is important to be familiar with the criteria for diagnosis. Those include non-extinguishable twitching, rhythmic lip or jaw movement, staring or eye twitching, extension of extremities, crunching of feet, and changes in vital signs, including apnea. Seizures should be controlled within 30 minutes of presentation using combination of the three main treatment drugs, phenobarbital, phenytoin, and diazepam. The loading dose of phenobarbital is 20 mg per kg as an IV slow push, with subsequent doses of 10 mg per kg after 20 to 30 minutes if seizures continue. No more than 40 mg per kg of phenobarbital should be given in one day. Phenytoin, preferably fosphenytoin, is a second agent to be used if seizures persist after the second or the third dose of phenobarbital. The loading dose is 15 mg per kg by IV, with subsequent doses of 5 mg per kg after 20 to 30 minutes if seizures continue. IV tubing containing glucose must be flushed with normal saline before and after use. Diazepam can be used as a second agent if phenytoin is not available. Give 0.1 mg per kg over 3 to 5 minutes as a first dose and repeat this dose after at least 15 minutes if seizures continue or reoccur. If seizures reoccur after acute treatment, start maintenance therapy 24 hours after the first loading dose of phenobarbital is given. The maintenance dose of phenobarbital is 5 mg per kg per day, given IV or per pills every 24 hours. In the unlikely event that a second agent is needed for maintenance therapy, give phenytoin at 5 mg per kg per dose IV every 24 hours. After 3 days of maintenance dosing without seizures, it is time to try discontinuation of therapy to determine whether or not the infant will require long-term outpatient anticonvulsant therapy. If the infant is on second agent, discontinue this agent first and monitor for 48 hours. If seizures reoccur, rebolus with another loading dose and restart maintenance. If seizures do not reoccur, discontinue phenobarbital and monitor the newborn for another 48 hours. If seizures reoccur here, rebolus with a loading dose of phenobarbital and restart maintenance. If seizures don't reoccur, discharge the infant home of anticonvulsant therapy. Anticonvulsant can cause apnea, especially when administered at high doses and in combination. Infants on anticonvulsant should therefore be monitored closely. In the case of apnea, be prepared to provide bag mask ventilation while awaiting the return of respiratory drive. An infant who has required an anticonvulsant must be observed for at least 48 hours after the last dose to ensure that seizures don't reoccur. When considering discharging patient requiring long-term outpatient anticonvulsant therapy, the drug the patient is on needs to be considered. Phenobarbital should be changed to pills and the patient can be discharged. Phenytoin, however, can't be changed to pills, so patient on phenytoin can't be discharged home. A rendezvous should be scheduled for all patients with HIE after discharge home, with the frequency determined based on the severity of HIE and seizures. The first appointment should be within 2 to 4 weeks. Newborns with devastating neurologic prognosis from congenital or acquired condition require special consideration. The severity of the expected outcome must be explained to the family honestly and clearly, and it is your responsibility to communicate and support them compassionately. Like all patients, newborns experience pain, though it can be more difficult to appreciate, especially if they are preterm. Repeated painful procedures have been proven to cause adverse long-term neurological effects. Minor procedures such as blood draw, IV placement, and lumbar puncture all cause pain for newborns. To control pain for minor procedures, give newborns sugar water with 1 teaspoon of sugar in 20 ml of clean water, as well as breastfeeding, comfort measures, holding, and saddling. For major procedures such as intubation, chest tube insertion, newborns should be given morphine at 0.02 to 0.05 mg per kg IV. This dose may be repeated once, with a maximum of 0.1 mg per kg per 4 hours. Morphine should be administered slowly to avoid respiratory depression. To review this material, we will go over a case study about a newborn patient, Francois.
Case studies.
He was just admitted to the neonatal ward and was born full-term. He required chest compressions at delivery, and his APGAR score were 1 at 1 minute and 4 at 5 minutes. What is your neurological concern? What is your goal temperature for Francois? Francois is at risk for hypoxic ischemic brain injury. A goal temperature is at the low end of normal range, below 37.5 degrees Celsius, as HIE can be exacerbated in the setting of hypothermia. 6 hours later, Francois has a generalized tonico-clonic seizure. You gave him 20 mg per kg of phenobarbital. The seizures continued, so you gave another 10 mg per kg 20 minutes later. Which side effects of phenobarbital are you most concerned about? Francois is at risk for apnea due to both the seizure and the anticonvulsant. He should be monitored closely, and you should be prepared to provide bag mask ventilation if needed. You decide to start Francois on maintenance phenobarbital because he has recurrent seizures. When would you discontinue the phenobarbital? You should discontinue the phenobarbital after 3 days without seizures. If the seizures reoccur, phenobarbital should be restarted and Francois should be discharged home on phenobarbital. If the seizures do not reoccur, the infant should be observed in the hospital for 2 days to ensure that there are no seizures as the phenobarbital level becomes subtherapeutic. Next, you decide to do a lumbar puncture to assess for possible meningitis as a etiology of seizures. Is this a major or minor procedure? What treatment could you give to control pain? This is a minor procedure, so you could give sugar water or breastfeeding, comfort measures, holding, or saddling.
Summary.
Now that you have finished this chapter, you should be able to identify appropriate temperature for newborns with hypoxic ischemic encephalopathy, HIE, explain the diagnosis and management procedures for seizures, identify dangerous side effects of anticonvulsant medications, identify treatment for pain associated with minor procedures, and identify a treatment for pain associated with major procedures. Consider these key points on neonatal neurology. The 3 main principles for treatment of HIE are avoiding hyperthermia, providing supportive care, and monitoring for and treating seizures. Seizures in newborns should be quickly diagnosed and aggressively treated. The first-line treatment is phenobarbital. A major side effect of anticonvulsant is apnea. Newborns on anticonvulsants should be monitored closely and provided bag mask ventilation as needed. Newborns experiencing pain from major or minor procedures should be treated according to the recommended pain management treatment. Thank you so much for your attention.
Please help us improve the content by providing us with some feedback.